I'll, welcome to Molly Murch. She is a stroke educator with Essentia Health in Fargo and is an amazing person. I've gotten to work with her on many different occasions. She runs the stroke support group, and they held an unmasking event a couple of years ago that went over really well. And she's a CBIS and all the good things. So we love having Molly as a resource here in Fargo in North Dakota. So I'll let you take it away, Molly.
Awesome. Hello, everybody. Thank you, Carly. Yes, I am Molly. I am the Stroke Program Educator at Essentia Health in Fargo. I've been a nurse for 16 years. Started off in med-surg nursing and then did some work in the general surgery clinic. Decided to go back and get my master's degree. So I am a UND alum twice, 2008 and 2020. So I was graduated both as a Sioux and a Hawk. And so became the stroke program educator in September of 21. Loved providing stroke education kind of throughout all the different entities. So nursing, hospital staff, EMS, rural communities. We do some education with elementary school and high school. So yeah, just love getting the word out about primary and secondary stroke prevention. So that's what we're going to be talking about today. I do have a video to open this up with, but let's see if I can get this to work now. Oh, I see all the faces now. All right, share screen. Right. Can you see that, Carly?
I can. There's that gray box there. Now the box went away. Yeah, now we're good.
All right.
I love sunrises. A lot of people love beautiful sunsets. I love beautiful sunrises because it says, hey, you made it to another day. My wife and I have been married for 43 years. I met her when I first got back from Vietnam. We have 3 beautiful daughters, and we have 7 grandchildren.
Dan is the best father that there could be. He is not a person or a dad that says no to any of his girls. Memories start for that day of, just loving, oh my gosh, I'm going up to the grandkids, tradition, hot dogs, the pumpkins, the kids are going to get dressed.
And as I was sitting there drinking, it was a cup of punch that they had given me, I noticed that I was drooling down the side of my face.
He comes walking over to me, not too long after we had arrived there. And he says to me, or tries to say to me, motioning and made some sounds coming out of his mouth. It's very difficult to watch a loved one go through something like that and not know how it's going to end up. Once the stroke happened, I guess I didn't sleep. I thought, is it going to happen again? The doctors didn't know for sure what was causing the stroke. So I felt like my husband Dan was a walking time bomb.
Something's going on with your heart. We want to monitor your heart activity. And then Dr. Maya said, hey, there's some new technology out. And I said, well, let's try it. They had a transmitter sit next to my bed. So every night at midnight, it would automatically talk to this chip. And so with my next appointment with the doctor, when he started seeing the results from this monitoring, he said, you've got AFib. it certainly was a lot of relief. It was, instead of looking over my shoulder all the time for every little, finger prick you got or whatever was happening at the time. Pay attention to your body again. It's always trying to tell you things. Either things are doing great or things are going a little off kilter. And if it's not real serious, obviously keep a log, keep a journal. Learn by it, examine it, explore it, persist.
All right. So I really like that video. He was just living his everyday life and going over to see his grandkids for a Halloween party, and all of a sudden he had symptoms. And in his case, as we're going to talk about today, he had undiagnosed AFib, so an irregular heart rhythm, which is a big risk factor for stroke. And so they figured out what was causing these events. Were able to get him on medication, and like it said, he's been stroke-free ever since. So now let's go back to my presentation. I got too many windows open here, guys. Sorry, give me a second. All right. Can you see that?
Yes, we can.
Awesome. So now, I'll move that back down here. All right. So today, again, we are going to talk about primary and secondary stroke prevention. I don't know why it's not letting me move forward. There it is. All right. So who can have a stroke? Anyone. Anyone can have a stroke. So a lot of times people have the mentality that, I don't need to worry about a stroke. I'm not old enough, or stroke can only happen to old people. And that is far from the truth. As the stroke program educator at the hospital, I will be honest, at Essentia, we have been seeing younger and younger patients coming in with stroke. So those in their 30s, 40s, 50s. And then, of course, we have, our older people, yes, 80s and 90s. But in the 3 years I've been in this role, we have seen younger and younger patients coming in with strokes. And we'll talk a little bit about why that is. So again, anyone at any age can have a stroke. Young, old, healthy, unhealthy, black, white, Hispanic. Nobody's immune from a stroke. So these are some famous faces that I'm sure you guys recognize of people who have had a stroke. Kirby Puckett is kind of the local guy from Minnesota back in the 90s. As you all know, he was a great baseball player for the Minnesota Twins. Unfortunately, Kirby had quite a few risk factors that maybe weren't being managed very well. And unfortunately, he suffered a hemorrhagic stroke in his 40s and unfortunately did pass. Betty White, of course. Betty was 99 when she had a stroke. They did determine, I should say, that she had a stroke 6 days prior to her death. And then some other familiar faces, FDR, Loretta Lynn, Dick Clark, Tim Curry, Randy Travis, Bill Paxton, oh my gosh, I'm blanking on her name, Della Reese, Luke Perry. So again, if we look at these faces, these familiar faces, there's not really anything common amongst them other than them being celebrities or being famous. But as you can see, strokes happen to all types of people. So let's talk about what is a stroke. So if you guys learn anything from me today, this is one of the big things. Strokes happen suddenly. So SNS, sudden stroke. 1 minute you're fine. Everything's going good. You're going about your day like you normally are. And then all of a sudden, something happens. You start to have weakness. You start to have slurred speech. You start to have a facial droop, and it's happening suddenly. That's your brain's way of saying, I'm not getting enough blood and oxygen up here, so I'm not going to work anymore. That's your body's way again of saying you need to go in and get help. Don't ignore those symptoms, okay? We always like to say in healthcare, time is brain. So every minute that someone is experiencing a stroke, they lose 2 million brain cells every minute. So think about somebody who maybe is having a stroke in the evening, and instead of going into the hospital, they say, I'm just not feeling very good. I'm going to lay down for the night, and it'll be better in the morning. And now they wake up the next morning, and it's not any better. It's actually worse. Well, they've now lost millions and millions of brain cells. So time is brain. So statistics, most people don't like statistics, but us in healthcare, we like statistics because it helps us to determine how are we doing with stroke care and how are we doing with educating patients on primary and secondary stroke. So every 40 seconds, someone in the United States has a stroke. So once a minute almost. The second bullet point, this is the one that's probably gotten the worst in the last few years. So when I first started this position in 21, it was every 4 minutes someone dies of a stroke, and it has gradually gotten worse now over the last couple of years. So I always like to pose the question, why do you think this is? Why do you think we're seeing an increase in death rate related to stroke? So people maybe not taking care of themselves as well as they used to, people not being as active as they used to. Technology is a wonderful thing, but at the same time, it's maybe not the best thing because it doesn't keep us as active as maybe we used to be. As you all know, the United States is a melting pot. We have lots of different cultures and ethnicities, and we're starting to see more and more of that in North Dakota and Minnesota. And so going and educating these people, sometimes there's that language barrier. I'll tell you that in the last couple months, we've had some stroke patients at Essentia in Fargo, and I have to utilize like a language line service because I need these patients to understand why they had this stroke and how they can prevent another one from happening. And if I don't use that correct language, they're not going to understand. Another reason why we're seeing an increase, I think, in our death rates, as you guys know, we have a drug epidemic in our state and our nation. A lot of people participating in, stuff maybe that they shouldn't be. So chronic drug use, chronic alcohol abuse. And over time, that drug and alcohol use can actually weaken the arteries in our brain, causing us to be at a very high risk for a stroke. So again, our death rate is getting worse. I'm hoping that we will maybe see it get better again. I guess time will tell. So the good news is, and we're going to talk a lot about this today when we talk about risk factors, 80% of all strokes are preventable. We cannot say that about a lot of conditions out there. So 80% of all cases are preventable, meaning if you know your risk factors, you're taking your medication, you're staying active, you know your family history, you can ultimately help yourself prevent yourself from having a stroke. Yes, there is that 20% where, somebody young has a really bad stroke, and we sit there and we kind of scratch our heads and think, why did this happen? They don't have risk factors, they're healthy. Why did this happen? And unfortunately, that's part of stroke care. So 50% of the U.S. population has hypertension or high blood pressure. Uncontrolled high blood pressure, we call that the silent killer. So if somebody's sitting out there for years and years and years with an elevated blood pressure and they don't know it, or they're not on medication, that's not good. Okay, that's really hard on the vessels and my arteries in my brain, in my heart, in my legs, in my kidneys. Untreated high blood pressure is the number one risk factor for every type of stroke we see. So when I go out to our rural communities and I do presentations with senior citizens, I sit and talk about 15 to 20 minutes with them about blood pressure monitoring. How do you check your blood pressure? Do you keep a log of it? What about your medications? So if you learn any other thing from me today, high blood pressure, if you have it, you need to keep track of your numbers. And we'll talk more about that in a little bit. So AFib. So the gentleman in that video we just saw had 2 cryptogenic strokes. And again, cryptogenic means, why did this happen? We don't really know why this happened, but we're going to figure it out. So that's why they put the heart monitor on him and said, yeah, you've got AFib. So AFib is an irregular heart rhythm. So normally our heart should go lub-dub, lub-dub, lub-dub. Sometimes what can happen is our hearts can go into an irregular heart rhythm where maybe they skip a beat, maybe they go really fast and then they slow down, and go really fast and slow down. That's not good. An irregular heart rhythm puts us at big risk for throwing clots from our heart. Okay, clots can eventually then break loose and travel up and go to the brain, causing a stroke. And we'll talk more about AFib and what you guys need to know about that in just a second. Smoking, pretty straightforward. Smoking puts somebody at a very high risk for a stroke. Smoking just is so hard on our arteries and vessels, causes constriction of our arteries and vessels, and now blood and oxygen can't get through those arteries and vessels. And now this is another big one. A history of a stroke in a first degree relative. So what do I mean by first degree? Mom and dad, brother and sister. Any family history in that first degree relative now puts that individual at a 12% higher risk for having a stroke. Second degree can also put that person at a higher risk, so grandma, grandpa, aunt, uncle. So knowing your family history and knowing if there is a strong family history of a stroke or any other cardiovascular issue is very important for your doctor to know.
So Molly, there's a question in the chat. If a person who has SVT and only had 2 major events, otherwise minor ones, are they at risk for stroke? Not
Great question.
What SVT means, I guess.
Yep. So SVT is supraventricular tachycardia. So a long word, and they make stuff so long sometimes in medical or healthcare. So pretty much what that means is where your heart just bump, 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 bump. It's super fast. So supraventricular, there's 2 parts of our heart. We have our ventricles and our atrium. So the ventricles are the lower part of the heart. And so when I have tachycardia, my heart is just pounding away. It is working really hard. So yes, if you've had a history of SVT, hopefully you've followed up with a cardiologist and gotten on some type of medication. But if you were in sustained SVT for a long time, that was hard on your heart. Okay, your heart was really working hard for who knows how long. So that definitely, I would say if that's continuing to happen, if you've been having more frequent episodes of that, definitely let your doctor know. But if you've only had 2 events and haven't since, that's good. But be very cognizant that if you start noticing those symptoms again, let your doctor know right away, because we don't like it when our hearts work super hard, because it puts us at risk for clots, puts us at risk for heart failure. I hope that helped.
Yes. And then she asked about if you're a former smoker, like, is it?
Yeah, very good. Very good question. So if you have stopped smoking, way to go. Congratulations. That is a huge accomplishment. Like Carly said at the beginning, I do the stroke support group in Fargo. And when we talk about, what was the hardest thing to do when you were, after you had a stroke, it was stopping smoking. So way to go. Yes, it puts you at risk for up to a point, because again, smoking, what does it do to our arteries? So this is my artery, nice and open. If you're a chronic smoker, what can happen is this can cause your arteries to do this, constrict. Your artery, your vessel gets smaller in diameter, and now oxygen and blood can't get through that as well as it used to. But now if you've stopped smoking, they actually say within 2 years of not smoking, you have significantly decreased your risk for a stroke. Great question.
Thank you.
And we'll talk more about that too here when we go a little bit deeper into risk factors. So really quickly, let's look at the different types of strokes. So there's 3 types of strokes that we see in healthcare. So ischemic, hemorrhagic, and TIA. So when we think of the word ischemic, we think tissue injury. My brain is not getting enough oxygen and blood. Why is that happening? So our hearts and our heads are connected, right? We need oxygen and blood here. We need oxygen and blood here. Otherwise, our heart doesn't work, our brain doesn't work. So oxygen and blood gets pumped from our heart up through our big arteries in our neck, called our carotid arteries, and into the blood supply in our brain. So what happens when we have an ischemic stroke is there's a clot that's blocking oxygen and blood flow. Now, whether that clot happens in the brain over time, so people with atherosclerosis, smoking, uncontrolled diabetes, what can happen again is those arteries in my brain get smaller, and now blood can't get through there as well as it used to, and little particles of blood start to collect in the vessel in my brain, and eventually a clot can form. The other type of clot we see, or type of stroke caused by a clot, is called an embolic stroke. Now, this is the more common one that we see. So embolic meaning it came from somewhere else. So maybe someone just had knee replacement surgery. Maybe someone has undiagnosed AFib. Okay? Maybe somebody has an undiagnosed blood clotting disorder. Maybe somebody who hasn't been to the doctor in 20 years and they have hypertension, hyperlipidemia, diabetes. What can happen is a clot can break loose. Most of the time it's the heart. So a clot can form in the heart, and all of a sudden that clot says, hey, I'm going to go on a trip. It breaks loose, travels up the bloodstream, and goes to the brain, lodging itself in my brain. That's not good. So in this picture you can see, this is my artery. Here's my oxygen-rich blood that I need. This clot has stopped this oxygen-rich blood. So up here, where my brain is, it's not getting its oxygen and blood. People have to start to have symptoms. So this is the most common type of stroke we see as an ischemic stroke. So a stroke caused by a clot. However, there's good news, you guys. We can treat these. However, time is brain. We need to get to these patients quickly. So in order to get treatment for ischemic strokes, patients need to be what we call within certain time frames of last known well. What do I mean by that? So let's say I go to bed, or the patient goes to bed tonight at 10 p.m. Everything's fine. Everything's good. The next morning, they wake up and they walk into the bathroom and they notice they're a little more weak on the one side. They notice maybe their face looks a little uneven. They've got a droop. Maybe their speech isn't very clear. What we mean by last known well is when that patient went to bed at 10 p.m. last night, they were at their last known well. Normal symptom, normal self. And now they've woken up the next morning at 7 or 8 o'clock and they're having symptoms. This patient, unfortunately, would not be able to get this clot-busting medication because they're too far out from that time frame. Okay? So that's why recognizing signs and symptoms as quick as possible is so important, because we only have 4.5 hours to get you into the hospital and get you this medication. The biggest thing to remember, though, with this medication is you also have to meet criteria. So even though if you meet the time, you also still have to meet criteria. Okay, any questions on that so far? All right, so let's say, though, you maybe all have maybe seen this, maybe some of you have experienced it, where we can have major strokes, where a clot has blocked a huge artery in my brain, and that artery in my brain perfuses half my brain tissue. These people are kind of the ones that when you see them, you're like, uh-oh, this isn't good. A lot of times with these patients, they're completely flaccid on one side. So their whole right side, for example, doesn't work. They can't move their leg. They can't move their arm. Sometimes they can't talk at all. If they do talk, maybe they just get a few words out or they're slurring their words. Again, if it's a really bad stroke, sometimes what can happen is their eyes can deviate one way, so they don't have that side-to-side movement. So with these patients, when they come into our hospital, it's kind of like, oh, yeah, we know that this is not good. But again, there's hope. If this is a big old clot in my brain, we actually have a team of doctors who can actually go up into the patient's brain with a device and actually get that clot out. Again, it all depends on when your last known well was. We can do this procedure up to 24 hours of last known well, and in some cases, if we have brain tissue that we can save, we can even do it beyond that. So here it is. This is a little bit more about this procedure I was just telling you about. So you or a family member or a friend all of a sudden develop significant symptoms. So again, weakness, speech issues, visual issues. We bring you into the hospital, we do some imaging, and sure enough, it shows you've got a big old clot in your brain. Again, we can go up into the patient's brain. So this is a picture of an artery in my brain. This is beautiful. Look at how nice and red and good blood flow here to my brain. But what's happening here? It's dying. Okay. Why is this area of my vessel and my brain dying? Because this clot is blocking that oxygen and blood flow. So again, what our doctors will do is they'll do some advanced imaging and see exactly where in the brain is that clot. And does that patient have any viable brain tissue? Meaning, if I can go up and get that clot out, can I help save tissue? So in this picture, this patient is actively having a stroke. Here is those big arteries in my brain. This little yellow thing here is a clot. This clot is blocking oxygen and blood flow to half my brain. So this person is actively having a stroke. This area that's black right here is dead. We're not getting that back, okay? That's why this patient is having a major stroke. However, what our doctors are looking for is this big old area of penumbra. It's kind of fun to say. Penumbra is an area of tissue that if we can get this clot out, we can get blood and oxygen reperfused to this area and hopefully save the person from having any more damage. And that is the difference between this size of a stroke, where did my mouse go? This size of a stroke and this size of a stroke. Okay, so again, what our doctors are going to do is take a catheter device or a retrieval device. They're going to rush you back to the IR suite or like the operating room. They're going to make an incision in your groin, and they're going to go up your blood, your vessels, all the way up to your brain. Okay? Once they're in your brain, they're going to see where this clot is, and they're going to advance this catheter and leave it in your artery for about 3 to 5 minutes. And it's going to tell that clot, come here, you don't belong in here, get out, okay? Once about 3 to 5 minutes is done, we pull that catheter back out through your body, and hopefully we got it. So this is an actual case we had at Essentia. And as you can see in this picture, we have good blood flow down the middle of our brain, but to the side of our brain, to the one side of our brain, all of a sudden, there's no blood flow. Okay? There's no blood flow because this person has this huge clot in their brain. So we went in and we took the clot out. Once we took the clot out, look at how much better that looks. Nice blood flow. Again, we didn't prevent the patient from having a stroke, but we prevented the stroke from getting any worse. So again, with this case, difference between possibly life and death, possibly going home versus being in a nursing home, because we were able to get into that patient's brain and get that clot out. Here's another picture. Okay, a couple clots that this patient had in their brain. As you can see in this picture, again, no blood flow to this area of the brain because of these clots. Once we took these clots out that look like little worms, right? Much better. So again, to summarize ischemic strokes, clots. We need to either bust up the clots with medication or we need to go up into the brain and get that clot out. Again, it's time sensitive. We need to, time is brain. We got to get up there, get the clots dissolved or taken out to get reperfusion back to the brain. So any questions on ischemic strokes? All right. So now let's go to the opposite end of the spectrum. We're not clotting, we're bleeding. Bleeding is not good either. We like blood in our brain, but we need to keep it inside the arteries and vessels. So these types of strokes we don't see as often, but they are out there. So just like there were 2 types of ischemic strokes, there are 2 types of hemorrhagic strokes. So I love this picture. This is our brain, everybody. This is how vascular your brain is. How many blood vessels and arteries we have in our brain. So yes, I have had patients in the past that will say, I'm confused. I thought I was supposed to have blood in my brain. And I say, yes, you are. We all need oxygen and blood in our brain, but the key is it needs to stay inside these arteries and vessels. The problem happens when one of these arteries or vessels breaks, and now we have blood on our brain. Is that good? No, that's not good at all. It's very bad, actually. Okay. So let's talk about the two different types of hemorrhagic strokes. So the number one cause of bleeding strokes is hypertension. So again, in our brain, oh geez, I went back too far. Sorry, guys. Okay, if you see in this picture where I'm circling right here, these are tiny little vessels, small vessels. These little vessels penetrate deep into our brain tissue to provide blood and oxygen way down deep in our brain. These tiny little vessels are highly susceptible to high blood pressure. So think of my fingers here as your tiny little vessels in your brain. Over time, maybe someone who has undiagnosed hypertension, diabetes, drug use, smoking, these little vessels eventually just get worn down and they say, I can't do it anymore. I can't handle this high blood pressure anymore. And poof, they break. Okay, that's not good. So we now have blood leaking onto our brain tissue. And we will talk about symptoms of a stroke here in just a second. But one thing I want you guys to know as far as bleeding strokes is, yes, you're going to have that sudden weakness. You're going to have some slurred speech. But the key difference with bleeding strokes is you're going to have a sudden, horrible headache. So horrible headache in my brain. I start to get nauseated. Maybe I have vomiting episodes. I check my blood pressure and it's 240 over 120. That's not a good sign. Okay. That pain, that severe pain in my head, the nausea and vomiting is my brain's way of saying, I'm got pressure in my brain. I have a bleed in my brain and the pressure is building and building and building. So we have the small vessels that cause what we call ICHs, but then we have our big vessels in our brain. So again, in this picture, you can see the small vessels, but then you can see the bigger arteries, these bigger arteries. What can happen in a perfect world, our arteries should be nice and smooth and beautiful. Look at those beautiful arteries. But unfortunately, what can happen is somebody can develop what we call a ballooning or an aneurysm on your brain. And maybe some of you know somebody who's had an aneurysm either in their brain or off their heart. That's not good. We can't have balloons in our brain, okay? There's no room for those balloons to do anything. But what can happen is somebody can develop an aneurysm, which is a weakened balloon area on the artery wall. So just like in this picture, this is a ballooned aneurysm, okay? So think about a balloon at a birthday party or a water balloon during the summer. As you're pushing air into that balloon, what are you doing to the walls? Stretching, stretching, stretching. Uh-oh, it blows. No different than this balloon in my brain. Someone who has chronically high blood pressure, smoking, alcohol abuse, drug abuse. Eventually, this balloon in my brain is not going to be able to take that pressure anymore, and it's going to blow. We now have lots of blood, not just a little, but lots of blood leaking onto our brain tissue. Not a good situation. These are very devastating. If anybody has known anyone who's passed from an aneurysm rupture, it's very devastating because a lot of times we don't know we even have these aneurysms in our brain until it's too late, until they've popped. However, there is hope, you guys. So, let me move this. I guess it's fine. So, symptoms, what we call a thunderclap headache. So you're going about your day and all of a sudden it feels like something blew up in your head. You get a sudden horrible headache. You start to vomit. You get just really sick. It's not a good situation. So of course we get you into the hospital and hopefully we can figure out what caused this bleed and get in there and fix it as soon as possible. I want you guys to pay close attention to what this says right here. Family history. If you have a first or second degree relative who has had an aneurysm, whether it's off their heart, whether it's in their brain, you need to let your doctor know. A couple of years ago at Essentia, we had a 51-year-old patient who had an aneurysm in her brain that ruptured. She almost died. Upon visiting with her, we found that her mom had actually died of an aneurysm rupture in her 60s, and now she has had an aneurysm rupture at 51. And so when it was my turn to go and educate the patient and her daughters, I turned to those two daughters and I said, you guys need to call your primary, and you need to tell them that not only your mom, but your grandmother have both had aneurysm ruptures, because you are now at a very high risk for having an aneurysm, which is, again, another mystery of the body, because my brain is different than my mom's brain, then is different than my grandma's brain. But there's that genetic predisposition for developing those aneurysms. So just know that. Yes, insurance a lot of times will not pay for prophylactic MRIs or CTs of the brain. However, if you tell your doctor, yeah, I've got this strong family history, a lot of times insurance will say, okay, well, yeah, we'll pay for an MRI, and you can see if there is an aneurysm there. So, fell asleep here. Hello, there we go. So bleeding strokes, yes, are very devastating. However, you guys, there is hope, okay? We don't just let these patients go. We are aggressive. If somebody comes in with a bleeding stroke, we can help them, whether it's medical intervention, surgical intervention, or endovascular intervention. Regardless, we can get to these people, get them treatment, and hopefully ultimately save their lives. We have quite a few patients that come into Essentia Health. Yes, some of them have pretty significant bleeds, but some of them have smaller bleeds, and we can get them treatment, figure out what caused this, most likely hypertension, and get them on the right path. So any questions on hemorrhagic strokes? All right, so we talked about clotting strokes, so ischemic. We talked about bleeding strokes, hemorrhagic. And now we're going to talk about warning strokes, or TIAs. We take care of a lot of TIA patients. And TIA patients are kind of my favorite patients because this is a warning sign. Okay, so for example, let's say a patient or a person is up at the local senior citizen center, or they're at a birthday party for a family member, just like the guy at the beginning of the video. He was at a Halloween party. And all of a sudden, he developed what? Drooling. His face was drooping, and he was having a hard time getting his words out. Two big signs of a stroke. So they rushed him in, and in his case, he did have a stroke. But a lot of times what happens with our TIA patients is, so let's say the patient has sudden weakness. They can't move their hand very well, their face is drooping, and they're slurring their words. We rush them into the hospital, and by the time they get to the hospital, their symptoms are better. They can move their hand just fine, they're talking normal, their facial droop is gone. This patient had what we call a TIA. So why did this happen? A clot, again, most likely from the heart, a clot broke loose, traveled up the bloodstream, and lodged itself in one of these arteries in the brain, causing what? Lack of oxygen and blood flow to the brain, causing the patient to have symptoms. However, the patient's body said, well, this isn't good. I need to take care of this. And it takes care of the clot on its own. Why we love these types of patients is that's a warning sign. We should never, ever, 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 ever be throwing clots. Our bodies are not designed to handle clots because they break loose and they lodge themselves in our arteries, our heart, our head, our legs, our kidneys, and all of a sudden, it's not good. Okay, so if we can figure out why these patients are throwing clots or developing clots, we can hopefully get them on the right track. Maybe this patient hasn't been to the doctor in 30 years. Maybe this patient has undiagnosed AFib. Maybe this patient has a little hole in their heart called a PFO, patent foraminal valley, that they've had since birth, and they haven't had any issues until recently. Again, if we can figure out what's causing these clots, we can get them on the right track, get them on medication, have them get a little procedure done, whatever it may be. And ultimately, what we're trying to do with this is prevent a full-blown stroke. Okay? For your guys' information, the nurse practitioner that I work with at Essentia in Fargo, her name is Megan Carl Bloom. She actually will see patients who have experienced TIAs. So if you or someone you know are experiencing TIA episodes, or you think maybe you had a TIA, you can actually ask your doctor for a referral to see Megan, and Megan will fast track you. She'll get blood work ordered, she'll get some testing done, and hopefully figure out what you're having these episodes. All right, that's the last type of stroke, TIA. Any questions? All right, so this is the big slide. You guys, if you want to, you can take a picture of this slide. But if you learn anything from me today, it's this: be fast. So this is something I'm really passionate about as a nurse and a nurse educator, whether it's presenting to people like you, whether it's presenting to senior citizens, my elementary school students, my high school students, my nurses, whoever it may be. Every person needs to know what be fast is. Well, why? Be fast is the acronym we use to recognize the signs and symptoms of a stroke. So balance, eyes, face, arm, speech, time. It used to be just fast, but we've added BE, balance and eyes, because we're finding a lot of strokes are happening in the back of our brain. And the back of our brain controls vision and balance and coordination. So if you look at this list, BEFAST, sudden. Is their balance and coordination suddenly gone? Did their vision suddenly change? Does the face look uneven, and did this happen suddenly? Okay. S and S, sudden stroke. Again, 1 minute the person's fine, the next minute, they can't see out of one eye. Or they're fine, and the next minute they're drooling and their face is drooping. The next minute I'm talking to you guys and all Molly's got sudden slurred speech. It's not good. Again, that's my brain's way of saying, hey, I'm not getting blood and oxygen up here. You need to go in and get help. So it's not just the acronym we use to recognize the signs and symptoms of a stroke, but it's also what we need to do. Be fast. Get to the hospital. Get evaluated. So do you wait till you have all 5 of these before you go in? I hope you're all shaking your head no, okay? No, you only have one of these symptoms and it's happening suddenly. You need to get in. We have had numerous patients over the last few years where the only thing they have is balance and coordination issues. So they come in and say, yeah, for the last 3 days, I've just been really dizzy. I've been on, my balance is off. My coordination just doesn't seem as well as it used to. So we work them up, and sure enough, they've had a stroke. Let's say I'm holding my cell phone, and I have my phone, and all of a sudden I drop my phone and my arm goes weak. That's not a good thing, okay? So be fast. Any questions on be fast? All right, so we've talked about strokes in general. We've looked at the different types of strokes. We've talked about how to recognize the signs and symptoms of a stroke, but now the all-important, how do we prevent ourselves from having strokes? So primary stroke prevention. So we all have risk factors. Every single one of us, me, Carly, everybody else out there, every single one of us have risk factors. The minute we're born, we have risk factors, okay? Whether those are risk factors that we can control or risk factors that we can't control, okay? So can we do anything about getting older? No, okay? What happens over time, again, in our body, whether it's arteries in our hearts, our head, our legs, our arteries when we're nice and young are open like this, okay? Blood and oxygen is getting through there nice and easily. But what can happen over time is those arteries get smaller. The diameter of my arteries gets smaller due to atherosclerosis and just due to aging, okay? So now all of a sudden my arteries are more like this instead of like this. That puts us at a high risk for a stroke. It is what it is. That's part of aging, okay? After the age of 55, your stroke risk doubles every 10 years, okay? Race. Can't do anything about your race. African Americans are at 2 times more likely to have a stroke than any other racial group. There's actually a gene that geneticists have identified that put African Americans at a higher risk for stroke, heart attacks, cardiovascular issues. Gender, women, sorry ladies, everybody out there, we're at a higher risk for stroke than men. So when I tend to ask this question when I do presentations, I get some funny responses, but ultimately, what is the reason why women are at a higher risk for stroke than men? Hormones. So women go through lots of hormonal changes during our life, but none more important than menopause. So once a woman hits menopause, up until menopause, we've got a protective factor to our body. Our body helps protect us up until menopause. So we don't have as many cardiovascular episodes up until menopause. After menopause, we lose that hormonal coverage because our hormones change. And when that happens, it puts women at a higher risk for stroke, heart attacks, cardiovascular issues. Okay. Also, women live longer than men. Life expectancy for women is about 2 to 5 years longer than men. So as you can see, again, age coupled with being a female puts us at a higher risk. Okay. We've talked about family history a lot. I'm going to say it again, though. Know your family history. If you have a family history of a stroke, let your doctor know. And then personal history. My computer has a mind of its own here. Personal history. If you've had a TIA or you've had a stroke, you're at high risk for having another one. And we're going to talk about secondary prevention here in just a little bit. Okay, but again, can't do anything about those. Can't do anything about age, race, gender, family history, personal history. But look at all the things we can do something about. This is a big old list. Okay, so let's talk about these. AFib. So again, the gentleman at the beginning in that video had an irregular heart rhythm that he never knew about until all of a sudden a clot broke loose from his heart, went up to his brain, caused him to have a stroke. And they didn't realize he had AFib until they put a monitor on him and said, yeah, this is probably why you had a stroke, because your heart rhythm is irregular. So what do you guys need to know about this? If you're ever out and about, it's starting to get nicer out. So maybe you're out in the garden, or you're out working in the shop, or out working in the field, and all of a sudden you notice, my heart feels a little weird, or my heart's really racing, or did my heart just skip a beat? If you ever find that your heart is maybe not doing its regular thing, maybe you feel like it missed a beat, that's not a good sign, okay? It could be that you have something going on with the electrical system in your heart, so you need to get it checked out. There's lots of different tests that they can do for these patients. EKGs, echoes, they can put a heart monitor on you like that patient at the beginning had, and they can track what is your heart doing while you're active and what is your heart doing while you're sleeping. For those of you who maybe have AFib, you're probably on some medication. Coumadin, Xarelto, Eliquis. I cannot say this enough. If you are on those medications, never, ever, 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 ever stop those medications abruptly. We have had numerous patients over the years that, my INR level's been fine for the last 5 months. I don't need to be on this anymore. Or, I skipped a couple days of my medications. It's not a big deal. Yes, it is. We have seen patients that abruptly stop their heart meds. A week later, they have a stroke or heart attack. So AFib, Carotid artery disease, this is a big one. So remember a little while ago I talked about our hearts and our heads being connected. We need oxygen and blood here. We need oxygen and blood here. So it gets from here to here through these arteries in my neck. They're big time arteries. So in a perfect person who doesn't have any risk factors or they're very healthy, this is their arteries. Nice and beautiful, okay? Look at how nice that blood can flow up from the heart to the brain. However, over time, just like we've talked about, our arteries can get clogged up, okay? Atherosclerosis, smoking, diabetes, uncontrolled diabetes. And again, our arteries can build up a plaque on the walls, causing the blood flow to not get through there. As you can see in this picture, that blood is struggling to get through this carotid artery. Okay? So during this point in my presentation, this is when I normally have people raise their hands and say, how many of you have had a carotid ultrasound or an ultrasound where they put the probe over your neck and look at your arteries? If you have not had that done and you're thinking, oh, I've got some of these risk factors, I probably should get this done. I've had this done. So sometimes in Grand Forks, Fargo, some rural areas, they actually have a vascular screening that you can go into the hospital. You pay $50 and you get a vascular screening done. And what they look at is they look at your aorta, they look at your neck, they look at your arteries in your neck, and they look at the arteries in your legs. And what they can do by looking at that is, do you have some stenosis starting to form? Because if you do, we need to do something about that. Now, whether that's starting you on some medication to help lower those levels of fat, or if you get to a point where you're starting to get pretty blocked. This artery is really blocked, like 75% blocked. We're going to have to get you in to see a surgeon, and we're going to have to get in there and clean that out. I will tell you guys, in the last month, we have had a couple gentlemen that have come in with TIAs, with a couple minor strokes, and when we do a workup on them, sure enough, their carotid artery is 90% blocked. Well, no wonder why you had a TIA or a stroke, because that artery is like this. There's hardly any blood and oxygen getting up to the brain. So that's why you start having symptoms of a stroke, because that blood isn't getting up there. So maybe ask your doctor again, hey, I heard this presentation and I'm wondering if I can get an ultrasound on my carotids just to see how things are looking in there. Okay. I have said it many times already. How many times has Molly said hypertension today? Carly, how many times? Probably about 50, right?
Yeah, a lot.
So, high blood pressure, the number one risk factor for every type of stroke we see. What can we do about it? Know your numbers. So when I was in undergrad school at UND with my BSN, it used to be that 140/90 was considered pre-hypertension. The American Heart Association and the American Stroke Association keep tightening our levels for blood pressure because they have found that untreated high blood pressure, again, is horrible. Horrible on our arteries, horrible on our hearts. So they actually keep tightening these levels. So as you can now see, if you are 140/90, you are considered hypertensive. And there's actually talks now that you are actually going to be now considered hypertensive if you're 130/80. That's the newest thing that's kind of maybe coming out. And that to me is crazy. So know your levels. How do we know our levels? So I'm sure you all know of Amazon or heard of Amazon. If you are on high blood pressure medications or you're concerned that is my blood pressure running high, you can go onto Amazon and get a nice blood pressure cuff for like $20. And you can check your blood pressure on your own. And then guess what? You keep track of that. Okay? Get a little journal and every day say, okay, this is my blood pressure in the morning. This is my blood pressure in the afternoon. The best time to check your blood pressure is when? Bright and early in the morning when you first get up? No. at night, at the very end of the day? No, because when we're right away in the morning, we've just slept. Our bodies are nice and relaxed, okay? We want to check our blood pressure when we've been up for a little while, okay? So maybe about 10 a.m. in the morning. That's a good time to check your blood pressure. Another good time to check your blood pressure is about 3 or 4 in the afternoon, because that blood pressure is going to most accurately reflect what is my blood pressure doing while I'm going about my regular day. We don't want to check it too late at night because our blood pressure naturally goes higher throughout the day, just like our blood pressure is naturally lower in the morning after we've slept. Along with high blood pressure, if you're on your medications, take them religiously, okay? However, let's say you're on 1 or 2 different blood pressure medications and you've been on these medications for 10 years. And now you're really good about checking your blood pressure, but you're noticing your blood pressure was doing this, staying nice and even. But now, starting to do this, every day it's starting to go up a little more. And you haven't done anything to change your lifestyle. You keep eating right, you're exercising, you're staying active, but your blood pressure is doing this. That's not good, okay? It could be that your body maybe has built up an intolerance to that medication and you need to switch it up. On the opposite end of that, I also want you guys to know there's something called hypotension, where maybe you're on 2 or 3 different blood pressure medications and you're noticing, I kind of feel dizzy upon standing, or I don't know, I kind of feel like short of breath sometimes, or I don't know, I'm just not feeling quite right. It could be that you have too much blood pressure medications, okay? Especially if you've recently lost a lot of weight, have changed your diet to where you're eating more healthy. Maybe you don't need to be on all that blood pressure medication, and again, your body is trying to tell you that.
So we got a question in the chat. Are those apps that monitor your blood pressure accurate? Do you know? A Fitbit, I suppose, kind of.
Oh, yes. Yep.
Okay.
Okay. So, not that I'm going to be biased, but when I was in school, the first thing we learned as a nurse is to take a manual blood pressure cuff or blood pressure. An automatic one, so if you put an automatic one on, that's pretty good. But those Fitbits, those things that you can get on your phone that check your blood pressure and pulse, it's better than nothing, I will say. But do not rely on that consistently, especially if you're on medication. Again, technology is a wonderful thing, but sometimes it's maybe not as good as kind of the old school stuff we do, the accurate blood pressure monitoring, okay? Did that help? Okay.
Yes.
Hypertension kind of goes hand in hand sometimes with hyperlipidemia or high cholesterol. So what is cholesterol? Cholesterol is fat in our blood. We don't need lots of fat in our blood. We have a certain amount. Everybody has a certain amount of fat in their blood because we need fat, okay? We need fat for energy. Our muscles like a little extra fat. But it's when we get to have too much fat in our blood. So every year, or every 6 months, but most likely every year, you guys should all be getting your cholesterol level checked. They actually say once you hit about 30 or 40, you need to be getting your cholesterol levels checked. So if you all have maybe kids or grandkids out there, encourage them to, hey, next time you go to the doctor, I think you should get your cholesterol level checked to see where you're at. Okay. Sometimes, can we do anything about high cholesterol? Yes, but also no. I will tell you this story, and my brother, I don't know if he knows that I talk about him during my presentations, but I have a twin brother. He is extremely healthy, very active. He's a farmer. He eats healthy. He works out, all of that. About 3 years ago, I finally got him in to go see established care with a provider because we're 38. So back then it was 35. And even with his very healthy living, healthy eating, doesn't smoke, doesn't drink, he had an elevated cholesterol level. I think it was like 220. And when he told me that, I said, what? You have high cholesterol? I said, no. And then a couple of years later, he went, and sure enough, his cholesterol level was still high. And I said, well, yours is probably not due to diet and exercise. You probably maybe have more of a genetic predisposition. Our dad had a little bit high cholesterol. So did Brandon probably get some of that? Yes. Okay. So again, knowing that family history, knowing what your predisposition is to high blood pressure and high cholesterol. Sometimes you can be the healthiest person, but that genetic predisposition just puts you at risk for high cholesterol. Okay. So every year, though, you should be getting what we call a lipid panel done. So lipid panel checks cholesterol, HDL, which is our good cholesterol, and LDL, which is our bad cholesterol. And these are the levels that you should be sitting at. Less than 200 for cholesterol, greater than 40 for your HDL, and less than 100 for your bad cholesterol. If you're starting to see your levels every year going like this, might need to talk to your doctor about switching up your diet. You don't necessarily always have to be, boom, you have high cholesterol, we're putting you on medication. No, my brother still isn't on medication, okay? But eventually, after a few years, if making lifestyle changes, maybe you've lost some weight, maybe you're eating healthier and your levels are still doing this, it might be time to get you on a medication. Diabetes. This one's pretty straightforward. Diabetes, keeping a good blood sugar level. Well, what is a good blood sugar level? 70 to 100. Okay, but a lot of times people maybe will have type 1 or type 2. With that, our bodies, our vessels, and our hearts and our heads, they don't like our blood sugar levels to do this. Spike, down, spike, down, spike, down. We need to keep a nice level. It's when we start having, all of a sudden one day I'm 400, and now I'm 80, and now I'm 300, then I'm 90. That's not good. That's not good on our kidneys. It's not good on our vessels. So keeping your blood sugars under tight control. So again, eat healthy, exercise, take your medications. Okay. I think everybody, since we've been young, we've all been told about the dangers of smoking and drinking too much. I'm not going to beat a dead horse. You guys know this. But I will tell you that when you stop smoking, look at the changes that happen within just a matter of minutes, hours, years, okay, months. It is hard. Smoking and drinking are addictions, okay? But if we can do something to help get you to stop smoking, limit your alcohol intake, it is going to be a huge change for your vascular system. I'm not saying you can't have a beer. I'm not saying you can't have a glass of wine. It's when you're over drinking and you're over drinking multiple days a week. That's not a good situation. Okay. Exercise and physical activity. Yay, it's finally getting nice out. It's sun shining here in Horace, North Dakota. So we like to be out and about. People like to garden, mow their lawns, work on their cars in the garage, be out and about in the shops. But of course, we have months of the year where we can't be outside. That doesn't mean we can't still get exercise. If you have a local gym or a local walking track, or even just doing a little workout video at home, getting moving, get your heart rate up, get moving, is going to ultimately decrease your blood pressure, ultimately help decrease your risk for a stroke. So exercise and physical activity is huge. All right, this one's hard. This one's hard for a lot of people, myself included. We love food, especially in this area of the country. Everything we do seems to be associated with food. Graduation parties, annual family picnics, going out to dinner with family and friends, kids' birthdays, weddings. We like food in this area, myself included, okay? It's hard. I'm not saying you can't go to the movie theater and have some buttered popcorn. I'm not saying you can't have a piece of cake at your grandkid's birthday. We just have to be cognizant, okay, well, I had buttered popcorn today, and I probably should watch myself tomorrow. When we're looking at what are foods that are not so good for our vascular system, salt, fat. Okay, so all I'm going to say is look. Oh, I forgot sugar. Sorry, salt, fat, sugar. So be more cognizant. Do you have hypertension? Is your cholesterol level a little high? Keep a close eye on your food labels. Okay, when you look at your food labels, on the back of your food labels, the big ones I want you guys to pay attention to are cholesterol, salt, sugar, and trans fat. We have seen a huge change with food products in the last few years where a lot of foods do not have that trans fat because they realized after many years that those kinds of foods are horrible. Okay? So just watch what you eat. Everything in moderation. All right, Carly, how am I doing on time?
You are good. I'd say you got about 10 minutes or so.
Okay.
It's 2:37 right now, but yeah.
So that was kind of all primary stroke prevention, preventing us from having a stroke. But some of you out there have maybe experienced a stroke or experienced a TIA. You can't change the past, right? But how can we prevent you guys from having a secondary stroke or additional TIAs? So a lot of the risk factors we just talked about with primary are very similar to the risk factors for secondary. Okay. I will tell you, we see a lot of patients that come in, maybe haven't been to the doctor in a while, maybe kind of know about their health, but meh. And now you have had a stroke. You've got AFib that you previously hadn't been diagnosed with. We checked your cholesterol level, and your cholesterol level is 260. So you have high cholesterol. We need to do something about these conditions. We need to get you on some medication, and you need to be more aware. Okay, so this is the same screen or the same slide that we looked at when we talked about primary prevention. Once you've had a stroke, you need to be aware of your risk factors. Okay, I already talked a lot about this. I'm going to talk about it a little bit more though. Hypertension. Closely monitor your levels, especially if you've already experienced a stroke or a TIA. So patients with no history of hypertension who experience a stroke or TIA should maintain their blood pressure less than 130/80. So if you've experienced a stroke, you've experienced a TIA, or any other vascular episodes like a heart attack or chest pain or whatever it may be, you need to be very careful where your blood pressure is at. Okay, in patients with a history, so those first patients have had with no history. They came in, they had a stroke, had no idea they had high blood pressure. Number two is patients with a history of high blood pressure who experience a stroke or TIA. Again, less than 130/80 is recommended for most patients to reduce the risk of a recurrent episode. Okay, 130/80. I told you we were going to see it. Okay, that's kind of the new level. We really like patients sitting about 120 to 130 over 70s to 80s. But again, talk to your doctor. All right, hyperlipidemia. This is a big risk factor, of course, for stroke. And a lot of times our patients who have had strokes have come into the hospital now. We check their cholesterol level and they're high. Previously, we're not on any medication. So in patients with a history of ischemic stroke with no known coronary artery disease, and their LDL cholesterol is less than 100, we're going to put you on, greater than 100, we're going to put you on some medications. This atorvastatin is the other word that we commonly see is called Lipitor. So Lipitor, we need to get that cholesterol level in your body down a little bit. Okay. In patients with a history of ischemic stroke with a history of high cholesterol. So again, number one, no history. Number two, you do have high cholesterol and you already knew that before you had a stroke. We're going to put you on another type of lipid lowering statin called, I can never say this one, Carly, how do you say that? This one I have a hard time with. I think it's Crestor. Anyway, E. Starts with E.
Sorry, yeah, I have no idea. I wouldn't even.
That's a hard one to say.
Is that to be? I'm not sure.
So ultimately, when we have, again, risks with high cholesterol, ultimately your goal is to get your cholesterol levels down. Less than 200 for your total cholesterol and less than 70 for your LDL, which is your low density lipoprotein or your bad cholesterol. Okay. Here is a list of commonly used lipid lowering medications. Lipid lowering meaning fat in my blood. I need to get that fat number reduced and prevent additional fat from forming. So some of you out there may recognize these medications. Maybe you're even on them. Okay, again, atorvastatin is our big one. That's Lipitor. Rosuvastatin, that's Crestor. Okay, and then these are the more common ones we prescribe patients. You do see a few other ones. Prevestatin is another common one. Simvastatin. It all depends on what your doctor thinks you need to be on. But ultimately, what we want to do is keep that amount of fat in your blood low, especially after you've had a stroke. All right, again, diet, the hardest one. Okay. If you are somebody who's had a stroke and you know your diet is not good, you eat too much fat, you eat too much salt, a lot of times we will actually prescribe our patients or recommend our patients to start one of the two diets, the DASH diet or the Mediterranean diet. Okay, in looking at these, there's a couple differences. Okay, so the DASH diet, limited saturated, that should say fat, not fat, sorry. Limited saturated fats and cholesterol and emphasize nut consumption. So we want you to increase your fruits, vegetables, and legumes, so your beans. Okay, we want to encourage you to switch from white bread to whole grain. We want you to limit processed meats, so like your sandwich meats, okay? Regardless if it's turkey or not, that processed sandwich meat is not good. Limit your bacon, limit your sausage, all the good stuff, right? And limit your steaks, your hamburger, your roasts. Instead, we want you to be eating that lean meat, fish, chicken, turkey, okay? Salmon is excellent. If you guys like salmon, that's a great food to eat to help decrease your risk for a lot of cardiovascular issues. Okay, fat-free or low-fat dairy. I don't know if you guys have ever looked at your 2% or your 1% milks. They got a lot of fat in them. Okay, and they got a lot of sugar in them, but some people just love their milks. Okay. Again, maybe switching from 2% to 1% or 1% to skim. Okay. And this would be the hardest one for me. Limit sweets, added sugars, salt, and sugared sweetened beverages. Like this right here, Dr. Pepper. This is my weakness, okay? Not good. So that's the DASH diet. The Mediterranean diet is something that's been really become very popular in the last few years. So the Mediterranean diet is, again, high monosaturated and saturated ratio. So meaning instead of cooking with your regular oils, we want you to start cooking with olive oil. Okay? And then, of course, we want you to eat some nuts, almonds, cashews, that kind of good fat. So high intake of plant-based foods like fruits, vegetables, and legumes, similar to the DASH diet. Again, high consumption of whole grains, so whole grain bread, cereals. Increased consumption of fish. Low consumption of meat and meat products. Low to moderate red wine consumption. I don't know why so much with that one, but and then moderate consumption of milk and dairy. However, with the Mediterranean diet, you can't just limit your sweets, you gotta cut them out completely. So the Mediterranean diet is really commonly prescribed for somebody who's had a stroke and has significant risk factors. Maybe they have AFib, hypertension, hyperlipidemia. They're at a very high risk for having a second stroke. So we really need to turn kind of their world upside down as far as when it comes to their diet, because they're at very high risk for having another stroke. Okay? Any questions on that? So again, whether it's primary prevention or secondary prevention, know your risk factors. Okay? I'm going to come back to that story in just a second. So in summary, and then I'll finish off with this video, 80% of all strokes are preventable. That is wonderful to know, but we need to know our risk factors, our uncontrollable and our controllable risk factors, and talk to your doctor. Hey, doctor, I'm really concerned about my blood pressure. Doctor, I've noticed my cholesterol level's been going up over the last few years. Can we talk about this? I said it throughout, I'll say it one more time. Hypertension is the number one risk factor for every type of stroke. Know your numbers. Keep track. And then finally, know the signs and symptoms of a stroke and be fast. We can help get you treated. If you start having signs and symptoms of a stroke, we need to get you into the hospital as soon as possible to get you treatment. So my last thing is you might recognize this gentleman. It's a quick little video of a famous Olympic athlete who had a stroke. And would you think an Olympic athlete would have a stroke? No. So let's take a quick watch of this. Can you see that, Carly?
It's still kind of gray, but is it loading maybe?
Maybe.
On my end anyway, so I'm seeing like a gray block.
Okay, let me just go here. And then I'll share it in a different way here. And share. Better now? Oh, shoot, I forgot to share volume.
Okay, that's okay. Just stop share and then reshare. Yeah.
One more time, guys. One more time.
Okay, no worries.
Hey, we're getting there. Share sound. All right. So, as we're watching this video, I want you guys to think of everything we talked about today. And then I'll open it up for some last minute questions. This is just a quick little 3-minute video.
I didn't know what was going on. Yeah, that's life. You just never know, what's going to happen. And the expectation, if you had asked me before, I would think if you're having a stroke, you probably know it when it's happening, but you don't. I stumbled. I had a lack of coordination in my left ankle, that I was feeling some tingling in my left arm. So my wife and I discussed it and decided, let's go to the emergency room just to be sure and see what's going on. The first thing they did was a CT scan, and they mentioned that it seems like maybe you had a stroke, but we're not seeing that. The next step was then to undergo an MRI. When I got out, tried to get off the table and to get to the bed, I couldn't walk at all. I couldn't stand. My first question was, will I be able to recover? And the team of doctors said, that is the question that everyone has, and it's the right question, but unfortunately, there's no specific answer for that. But when you can't move something, you want to know, is this my future? I was very fortunate there was no brain issues. When the therapist came to my room and get you up with this walker and ended up walking 200 meters or thereabouts, which was ironic given that I was the fastest man in the world at that distance. It probably took 10 minutes for me to cover that distance that day, but I wasn't discouraged because I was taking instruction from my therapist the same way I took instruction from my coach. And it's what made me return to my room and tell my wife, I'm confident I'm going to make a full recovery. I was truly having to learn how to walk again. My motivation was phenomenal. My son is just going off to college, actually. I want to obviously be around for him and grandkids if I'm so lucky to have them, and I don't want any restrictions. I want to get back my quality of life. This was different. It was all of a sudden going into therapy and going into the gym every day, twice a day with a real motivation. Nobody's clapping. There are no gold medals when I finish, or runs on the track or in the weight room. That's a greater motivation than winning an Olympic gold medal, to be honest. Now it's more of trying to make sure that I take the time to relax, even if I don't feel like I need to. Relaxation for me a lot of times is go do a workout. Just sit down, and I do that a lot more and meditate, and that's good for me. Being a stroke survivor is part of who I am and always will be. I'll never know what caused this stroke. All I can do is do all that I can to minimize my risk of a stroke and live my life.
So I think that was a really good way to end. If you guys didn't know who that was Michael Johnson, famous Olympic athlete back in the 90s. Like he said, was the fastest man on earth. He suffered a stroke. I mean, you don't get much healthier than an Olympic athlete. So what caused his stroke? Maybe some family history, maybe some genetics. We don't know, but like he said, I'm a stroke survivor. That's who I am. And now going forward, I know my risk factors and I do what I can to prevent another stroke from happening. So that is all I have. Any questions?
Molly, I have a question. So I had to be on a phone call for the first part. Did you talk about the risk of stroke with TBI, like after traumatic brain injury?
I didn't, but that is a great thing. So when we think about our brain, okay, we're not getting too much into the anatomy lesson, but our brain is, so our central nervous system, we have our brain and spinal cord. So whether it's a TBI due to an accident, whatever, a fall, whatever it may be, or a non-traumatic thing where like a stroke, where it happens, it just happens. Regardless of when that happens, I have had damage to my brain, okay? An area of my brain that's maybe not working like it used to. And when that happens, it does put you at a higher risk for a stroke because, again, with your TBI, you've now experienced some damage to your brain. That area is maybe not working as well as it used to. So, again, my blood flow might change a little bit. My vascular area of the brain where my TBI was is going to put me possibly at a higher risk for a stroke eventually.
Thank you. Do you think that has so with young people, do you think that there's an equal risk for stroke after TBI, or is that more so with older people?
Great question. I think anytime you have any type of injury to your brain, it's going to put you maybe just at a tiny bit higher risk than somebody who at the same age hasn't had that TBI. But of course, then it all comes back to, okay, well, I've had a history of a TBI, but I also have high blood pressure. I have uncontrolled diabetes in addition to this TBI. That I really need to be aware of that and make certain changes to decrease that risk. You can't decrease the risk, obviously, from a TBI. Your TBI is one of those uncontrollable risk factors. You can't do anything about that. But just know, obviously, prevent additional damage to that area. And then, of course, know your other risk factors because, yes, you are at just a little bit higher of a risk.
Very helpful. Very helpful. Anybody else have any questions? Do we have any in the chat? Let's see here. So Alicia Anderson, you mentioned having to limit fat for brain health. I'm curious with that. Since I thought fats were good for the brain, also, is there target grams of fat that would be best for the brain?
Wow, that's a good question. That's an in-depth question. So you know how we talked about, it's all about when you're preparing your food, what kind of oil, what kind of fat are you using? Are you using butter to fry your stuff? Are you using oils and fats that maybe aren't as good? So it's that monosaturated fat we really like you to start using in preparing your foods. So that olive oil, vegetable oil are really good. And then, yes, we do need fat. We need fat for our brain. fat for our muscles, fat for our energy. Again, it's all about the correct type of fat. So nuts, like I said, nuts are really good. Yeah, they're high in fat, but it's good fat. It's that monosaturated fat. So almonds, cashews, those kind of things are all really good. Legumes, like we talked about, sometimes those can be a little bit higher, like edamame. A lot of people like edamame. That's really good too. I hope that helps.
Very helpful. Anyone else? Yeah, like 3 minutes left.
I see in the chat somebody had mentioned, Sherry had mentioned about blood pressure, and what if it's different from, let's say you're following up with a couple different doctors, and what if it's good with one doctor and it's not good with the other doctor? Just like blood sugar, our diabetes, we like our blood pressure here. You need to keep it in that nice range. The problem is, what if one day all of a sudden my blood pressure is super high? And now it's super low, super high, super low, or high, and then it goes back to normal. That's not good for our vessels to have those spikes, okay? That means all of a sudden my heart's really having to work hard, and then not so much. Really having to work hard, not so much. So really it's about keeping that blood pressure in that nice range, is very important. And then Sherry, you also asked about the carotid. I'm guessing about the carotid procedure. Again, the first step is going into your provider, asking about a vascular screening, about the carotid screening. And if you are showing increased stenosis or blockage in your arteries, absolutely, most likely, insurance is going to cover that, because if we don't fix that problem, you could very well have a stroke, and then it's a different situation. So definitely follow up with your doctor as far as if you have some of these other risk factors, maybe you would benefit from a vascular screening.
Did you see the last question on there too from Jessica about the DASH versus the Mediterranean, I'm assuming?
Yep. So I've tried the Mediterranean. It's hard. The DASH diet says free, fat-free, low fat. I would say start with the DASH diet. If you are, after we've talked today, and you think, oh yeah, my cholesterol's a little high, or yeah, I really should be maybe watching my salt intake a little better, start with the DASH diet. Don't go full bore for Mediterranean. Start with the DASH diet. See if you can handle that. And if you notice a change maybe in your blood pressure, maybe you've lost some weight on the DASH diet, that's good. But now you want to take it a step further. You're handling the DASH diet well, but you want just a little more. You want to lose a little bit more weight. Your cholesterol levels are still just not quite right. Then you can progress to the Mediterranean diet. But again, anytime you're doing these special diets, you've got to talk to your doctor first.
Any other questions there? Oh, I see something popping. Okay.
Yeah, so recently saw a cardiologist and told low fat, and I was surprised because I thought good fats are better. Yeah, again, every person is different, every patient is different, every stroke survivor is different. What are their levels? What is their blood pressure doing? What is their cholesterol? What is their diabetes level? That's going to help to guide our doctors to say, we're going to put you on this diet. We think you're going to benefit most from this diet. And then 3 months later, and you haven't had any benefits, let's change it up.
Good info. If no one else has any questions, we are at 3 o'clock, so we can let Molly go. And Molly, did you give your information, or let's see if Carly put it in case they have questions after this?
Yep, so I can actually, let me just share my screen one more time and you guys can write down. Yes, and if anybody has any additional questions, if any of you are from a small rural community and you think this would be a good presentation to have, if you want me to come out and speak to a group, I love that. I love coming out to our rural communities and doing education. So this is me at the very bottom, Molly Murch. And so my email address is just Molly Molly.Murch, so Molly.Murch at essentiahealth.org, all one word. And then this is my number at work. So, yep, if you have any additional questions, you're interested in getting some type of presentation set up for maybe your local community, I'm more than happy to do that. So,
Did I type that right in the Mrs. Molly.Murch
yes,
at essentiahealth.org?
that is me.
Okay.
Yep.
All right. So if you need to copy and paste it, anyone, it's in the chat. All right. Well, thank you so very much, Molly.
Yes, thanks for having me.
And thank you for being a wealth of info for our whole community and for speaking today.
Thank you. You guys have a great week. Enjoy the nice weather.
You too.
All right.
Bye-bye.
Bye.